to at least the 27 counties that REP captures right now. And then I think eventually the goal is to do it for the entire country, but I'm not sure on that because they have to index a lot of different data to plug into their models. So yeah, thank you.
Thanks. Ashmita, I would love to hear more from you about how this system can be used in the future. Like, is it already available? And then what does it kind of replace, or what does it? Yeah.
Yeah, thank you for that question, Molly. So this system, for example, the hollow fiber membrane module, it is available commercially. So this system was actually, when they introduced it, it is mostly used in purification, ultra purification. However, we are utilizing that utilizing that high absorptive area it has, and kind of exploiting that factor it has in our research. So this has not been used per se in oral drug absorption, but we are utilizing that to see if it could be utilized in this kind of setup to understand oral drug absorption for different drug products. So we are testing that specific module here, and this is available commercially. It could be used by in different purification, and we are utilizing that concept, that specific module, to make this specific dissolution hollow fiber system. And in terms of what it could be used in future, it is mostly for our research purposes. We have been utilizing this as a permeation model. We have been utilizing this as a permeation model that could kind of give us that advantage of different performance of the drug products, and can also help us assess the drug product quality in terms of different kinds of products from like different BCS classes, really poorly soluble to, all those different classes of drugs we have. And with that increased interest, or increased also event of poorly soluble drug, which are not soluble at all, and you have to kind of make these drug candidates into different kinds of formulation. You have to utilize really enabling formulation techniques to make these drug products available to the patient to kind of give that therapeutic effect. So this module could actually be helpful when you are trying to understand those really complex formulations, when you're trying to understand an assessment of what is the performance like when you are thinking of in vivo, when you are thinking of human. So that could be something it can be used, and we were actually able to see that it has great advantage, and further investigation will also be performed in future. And yeah, that's basically about it. Does that answer your question?
Yes, it does. Thank you very much.
Right.
Yeah. Usman, I wonder if I can ask you to talk a little bit about that. I was very curious about the finding that you were able to get more sort of concordance with a binary outcome versus continuous. Can you talk a little bit more about that?
Definitely. Thanks for asking. So also, thanks for getting my name pronunciation right. That's very rare, so appreciate that. But exactly, so we found that dichotomous outcomes had greater concordance, and we hypothesized a few reasons for this. One was that typically the dichotomous outcomes were associated with these hard objective measures and may have been easier to measure and could have been standardized across the board. Things like mortality, hospitalization, incidence of viral clearance, rather than some of the continuous outcomes, which were, for examples, time to symptom improvement, duration of hospitalization, time to viral clearance, which could have differed in terms of measurement, and I think is harder to necessarily define. The second is that we also found that the continuous outcome, the pairs that had continuous outcomes also had fewer studies associated in each pair. And so it could have been the case that with fewer studies, there may have been spurious findings across those studies, and that may have also decreased the agreement, harkening back to the point that the pooled evidence is also helpful to consider.
Yeah, thank you. And Vishal, I wonder if I can just ask you to give us a little update on where you are with your study and when you think you might be able to start recruiting.
Yeah, we're actually planning on starting recruiting next week.
Yay!
Yes, so just needed laboratory clearances, BSL-3 procedures in place, and other logistical issues, but hopefully starting soon.
Great. Well, thank you all. This was a really fantastic panel and fascinating papers. Thank you all. I believe we are now going for a break and we are going to return. Is that right?
Yeah, Molly, we're scheduled to come back, and I'm sorry, the Yale internet threw me off. We're supposed to come back at 2:45, but why don't we?
Oh no, he just went out again. So we're scheduled to come back at 2:45. So I think he was probably about to say, why don't we give it a couple more minutes beyond that? So I'm going to make it a 12-minute break. So everybody come back at 1:50/2:50.
You would think that coming into the office would enable more reliable internet.
That's not 2022. I am absolutely delighted to open up session 3. Session 3, as Joe was saying, we grouped them together as best we could. I'm going to call this one a methods session, looking at methods of understanding and completing studies so that we can better understand what we're finding in these studies. So we're going to start out with Alex Everhart from Harvard. And if you can just give yourself a very quick introduction before you talk, and then take it away.
Great. Great. Hi, everyone. My name is Alex Everhart. I am in my first year of a 2-year postdoctoral research fellowship at the Harvard-MIT Center for Regulatory Science. And today I'll be presenting on predicate characteristics and recalls of 510K medical devices. This is joint work with Soumya Sen, Yi Ju, and Pinar Krajmandich at the University of Minnesota, as well as Ariel Stern at the Harvard-MIT Center for Regulatory Science. Before I get started, I just want to acknowledge that I was previously employed by Medtronic PLC, a medical device manufacturer, and that this project was funded in part by the University of Minnesota's Office of Clinical Affairs Bold Ideas Grant Program. Primary motivation for this work is the fact that most U.S. medical devices in the United States enter the market through the 510K clearance process, where an applicant demonstrates that their product is substantially equivalent to one or more predicate devices. So here's an example of what that looks like in practice. This is a submission from Medacta International, the motolateral partial knee system. Medacta compares its applicant device to 3 predicates: a prior version of the Moto partial knee system, as well as 2 knee replacements from Smith & Nephew and Zimmer. Medacta compares its applicant device to the predicate based on dimensions like the material used, how the device was sterilized, and underlying mechanical principles. However, you'll notice that nowhere in this table is any discussion of human clinical evidence. And indeed, that is not a requirement for 510K devices, and most 510K devices do not come to market with any sort of human evidence. So it's perhaps not surprising, given that direct safety evidence isn't available at the time of market entry, 510K medical devices can have underlying safety concerns that are only detected after they're used in patients. A classic example of this is the Dupuy ASR XL metal-on-metal hip implant, which first entered the US market in 2008 without any clinical evidence. After the product entered the market, it was demonstrated that because the metal head and metal cup of this system ground together, dangerous metal ions were released into patients' bloodstreams, and the product was subsequently recalled in 2010. So prior research has documented how this was a clear failure of the 510K process. The ASR XL was compared to other predicate hip implants that did not feature the same metal head and metal cup design. So a larger lesson here is that just demonstrating substantial equivalence does not guarantee post-market safety. Seemingly minor differences in design between the applicant and predicates can have substantial implications for patient safety. And this problem is well known at this point, with many calls for reforms for the 510K process, particularly during the past decade. However, reforms to 510K have been slow, I think in large part because most of our concerns about the process have been primarily motivated by a handful of after-the-fact case studies like metal-on-metal hip implants. With that in mind, our team wanted to perform a more comprehensive and systematic analysis and ask, are certain predicate characteristics associated with the probability of 510K recalls? Fortunately, in terms of the data we would need to answer this, FDA does not report predicates used in 510K submissions in a research-ready format. We instead had to collect that data ourselves. We used an automated text extraction algorithm to create a database of 510K predicates. So we started off by downloading every publicly available summary of evidence document for 510K devices cleared between 2003 and 2018. From these documents, we first extracted the 7-character identifier for the applicant device, and then we used our automated program to extract the identifiers for all predicates cited in the application. We then repeated this process with every public summary of evidence in order to create a comprehensive database that describes the predicates used in 510K submissions. We ended up processing about 49,000 device documents in total. Many of these devices were excluded from our final sample, though, due to missing predicate information, where predicates were listed by name only, had incorrectly formatted ID numbers, or just weren't listed at all in a public document. Or among documents where predicate information was available, our algorithm performed very well. In comparison to a manually coded sample of devices, our algorithm had perfect accuracy, meaning the algorithm correctly identified all of the predicates in the document and only the predicates in the document 92% of the time. Using this data, we examined whether predicate characteristics were associated with the 510K device's recall risk. And here's a high-level overview of our main findings. But first, we find that devices that cite newer predicates face higher recall risk. So this is an unadjusted bin scatter plot where the x-axis is collapsed into bins with roughly the same number of devices in each bin, and the proportion of devices that experience a class 1 or class 2 recall is calculated within each bin. And then the plotted fit line is derived from a standard linear probability model. About 11% of in-sample devices experienced a class 1 or class 2 recall. And we find that increasing the age of the newest predicate by 1 year is associated with a 0.3 percentage point decrease in the probability of experiencing a class 1 or class 2 recall, or about a 3% decrease relative to the mean recall probability. And that effect size is attenuated slightly after adjusting for other predicate characteristics, product type, manufacturer, and year of approval. We also find that devices that cite more predicates face higher recall risk. Citing an additional predicate is associated with a 0.6 percentage point increase in the probability of experiencing a class 1 or class 2 recall, or about a 5% increase relative to the mean recall probability. And again, the effect size seen here is modestly attenuated after adjusting for other device characteristics. Finally, we find devices that cite recalled predicates has higher recall risk. About 5% of 510K devices in our sample were compared to a predicate that had an ongoing recall at the time the applicant device came to market. Each additional ongoing predicate recall is associated with a 7.1 unadjusted percentage point increase in the probability of experiencing a recall. We find that the effect size decreases substantially after adjusting for other predicate characteristics, product type, and manufacturer to a 1.6 percentage point increase in recall probability for each additional ongoing recall. However, that's still about a 15% relative increase compared to the mean recall probability. What takeaways? I think the findings from our work have implications for both clinical practice and regulatory policy. Regarding clinical practice, I think the implications are pretty straightforward. Devices that cite newer predicates or predicates with ongoing recalls have higher recall risk. So absent any changes to regulatory policy, physicians should take those predicate characteristics into consideration when deciding which medical devices they might use in surgeries or clinical practice. Another takeaway from our research, we believe that the FDA should make predicates used in 510K submissions available to the public. Our research shows that their predicate characteristics are associated with safety concerns, and yet for a large number of devices that weren't included in our sample, these predicate characteristics aren't available. So given that predicate characteristics say something about device safety, we think it's reasonable to ask that patients and physicians have information about these predicates and how 510K devices ultimately come to market. Finally, our research sheds light on potential reforms for the 510K pathway. Given that 510K devices that cite predicates with ongoing recalls face higher recall risk themselves, a reasonable restriction could be that 510K devices should not cite predicates with ongoing recalls. Such a restriction would have affected about 1 in 20 in-sample devices that came to market in 2018. Additionally, given that devices that cite newer predicates face higher recall risk, the FDA might consider a cool down period of sorts where a device would need to be on the market for a certain number of years before it could be used as a predicate in a 510K submission. Thinking about what that threshold might be in practice is tricky, though, as even requiring all predicates to be on the market for just 1 year before they're cited would have affected 1 in 4 in-sample devices that came to market in 2018. Oh, and the last thing I'll say is that we make these suggestions, last two suggestions, a little bit tentatively, just because it's not entirely clear to us how much flexibility there is in predicate choice in the 510K submission process. So for example, if hypothetically a device that came to market last year cited a brand new predicate, could they have it instead, like it's cited a much older predicate without actually changing the underlying technology in the applicant device? So I'd just be curious to get a sense from anyone in the audience if you have feedback on how binding these restrictions might actually be. Thank you all for your time. I'm happy to take questions during a Q&A session, or feel free to reach out over email and Twitter, which I am very active, if not too active on. Thank you.
Fantastic. This is a great presentation. Thank you, Alex. This is fascinating. We will take questions. I think we can take questions at the end. Our next scholar is Andrew Sang from Mayo Clinic. Is he present?
Well, this is Jessica. Sorry.
Okay.
So Andrew had some unexpected clinical responsibilities
Okay.
to attend to, so he won't be able to present.
Okay. So then let's keep going, because then maybe we can make up the extra time at the end. So Jason, are you ready? I know that was unexpected for you.
Yes, I'm ready.
Okay, great. So our next presenter is Jason Davidson from UCSF. Do you want to just introduce yourself quickly?
Yes. Hello, everyone. My name is Jason Davidson. I'm a second-year graduate student at UCSF. Where's presentation? There we go. Do you see?
You're in presenter mode? So you just swapped. Yeah.
Let me.
There you go. Oh, no. There, perfect.
Okay, awesome. All right, so hello, everyone. I hope everyone is doing well. Today, I'm going to talk to you about understanding the impact of demographics and socioeconomic parameters on treatment selection and utilization in type 2 diabetes. So before we get started, let's talk a little bit about what are social determinants of health. Social determinants of health are conditions in the environment where people are born, live, learn, work, play, and worship in an age that affects a wide range of health functioning and quality of life outcomes and risks that includes neighborhood built environment, education access and quality, healthcare access and quality, economic stability, and social and community context that all plays a role in health outcomes, drug effectiveness, disease risk, and quality of life. So the disease model which we're studying social determinants of health is type 2 diabetes, which is the result of pancreas' inability to produce enough insulin to regulate glucose homeostasis, where risk factors include weight, age, fat distribution, and demographics. From year to year, the prevalence of type 2 diabetes continues to increase, as well as comorbidities that are consequences of type 2 diabetes. And by the year of 2040, we're expecting 642 million patients to be diagnosed with diabetes. So what is the influence of social determinants of health on health outcomes? Disparities in diabetes burdens exist in large part because of social determinants of health, which affects the individual's subpopulation and population levels through socioeconomic status, living and working conditions, multi-sector domains, social, cultural, and social political context, where the next generation of diabetes translation requires a health equity goal, consensus definitions, core measures, multi-sector partners, macro and micro level interventions, and enhanced training and expanded function, all to provide diabetes prevention and treatment for an overarching goal of creating more equitable healthcare in this realm. So the data source we use to investigate social determinants of health and how they affect type 2 diabetes is the University of California Health Data Warehouse, which is comprised of 6 academic health centers serving different parts of California: UC San Diego, UC Riverside, UC Irvine, UCLA, UCSF, and UC Davis. In this data warehouse, we have over 8 million patients, and it's also represented by 12 hospitals. De-identification of this data has already been completed to enable clinical research projects, and the data is stored in the Observational Medical Outcomes Partnership Neutral Open Data Model, which enables a wide range of software tools and computational methods to be used within a community of more than 400 researchers in machine learning and artificial intelligence across the UC health system. In real-world data studies on type 2 diabetes, it has shown that early real-world data studies have improved our understanding of treatment practice of type 2 diabetes, but the utilization and health outcomes of type 2 diabetes treatment does not represent social determinants of health, which has resulted in a lack of knowledge on which treatments are most effective and most widely distributed across distinct population groups. In this figure by one of the former members in the Butte lab, which I'm in now, Thomas Peterson did a study on the differences of treatment distribution on monotherapies between type 2 diabetes drug classes for metformin, insulin, sulfonylurea, meglitides, DPP4s, SGLT2s, GLP-1s, and the dual therapies and the triple therapies. And it shows the variations of treatment distribution amongst patients across the UC health system. But now it's time to take it a step further and determine what role does social determinants of health play on patient distribution and health outcomes. So we hypothesize that treatment selection and health outcomes in the context of type 2 diabetes may be influenced by social determinants of health. The questions we asked to answer these questions, test our hypothesis is: one, what role does social determinants of health play in disparities of type 2 diabetes treatment utilization and efficacy? In aim one, we will answer what is the demographic and socioeconomic backgrounds of patients receiving type 2 diabetes treatments? How does social determinants of health impact treatment selection across population groups? And which type 2 diabetes treatments are most effective for lowering hemoglobin A1C levels in subpopulation groups to determine treatment efficacy? So we ask ourselves with these questions, what metrics can we use to understand the underlying causes of treatment selection, health outcomes, and how can we use social determinants of health to answer these questions? We plan to use that by using Area Deprivation Index. So Area Deprivation Index is a multidimensional evaluation of a region's socioeconomic conditions that are linked to health outcomes, comprised of 17 different calculated census tract variables that are categorized by education, housing, poverty, and employment status. ADI is important for this study because it will be used for one, risk adjustment to improve predictive models at an institutional level, two, to identify high-risk patients, and three, to design better care pathways that will improve health outcomes across the board. In the UC Health Data Warehouse, we have patients that are located in the San Francisco Bay Area, which is UCSF, Sacramento area, which is UC Davis, San Diego Riverside, which is both UCSD and UC Riverside, and the Los Angeles County area, which is UCLA. And across each health system, we have over 5 million patients that are linked with Area Deprivation Index information. And in each area, you can see the diversity of patients, where the blue areas are a least deprived area, meaning a more well-off economic area, while the red shows more deprived areas where more patients are in poverty. In each area, you can see the diversity of patients overall, which makes it extremely novel to run this study in the UC Health Data Warehouse due to the diversity of patients. So in aim one, we're characterizing social determinants of health for patients receiving type 2 diabetes medications. So we will perform cohort defining and phenotyping, where we take patients with a type 2 diabetes diagnosis with primary treatments treated in the UC Health Center that are linked with ADI percentile information. Then we will extract new instances of medication from patients in the system. And then we would characterize those patients by sex, age, race, ethnicity, ADI percentile, and BMI information. And then lastly, we will perform a multi-institutional analysis of treatment utilization UC health-wide and by each UC individually. Aim 2 is to stratify race and ethnicity to investigate the variation of treatment prescription across ADI decile groups. So we will perform a systematic review of type 2 diabetes treatments and assess the treatment patterns across demographics and ADI. We will identify patient subgroups of ADI percentiles and understand which populations are being prescribed certain treatments over others and how does that play an effect in their health outcomes. Lastly, in aim 3 is to investigate the impact of ADI on social determinants of health and type 2 diabetes drug effectiveness. We will first create a patient feature design matrix comprised of our social determinant of health covariates, which will be age, sex, race, ethnicity, ADI decile information. We'll also include medication use and lab test orders from hemoglobin A1C test scores. Then we will perform logistic regression to estimate the propensity scores that will be used to match patients and compare effectiveness between different treatments, where we will compare the first time reduction of hemoglobin A1C below a level of 7, less than or equal to 7 within 730 days of initial treatment, which will help us assess the effectiveness of treatments. Then lastly, we will quantify the effectiveness of each drug by ADI information by using the effective treatments to categorize those treatments by their distribution. So in this study, we ask ourselves, what are the potential limitations and how are we going to overcome those limitations? So for one, patients that don't have ADI information will be excluded from the data set. If time of outcome ascertainment is undefined, then it will affect defining treatment outcomes in patients, which will also affect us understanding the effectiveness. Infrequent doctor visits and prescriptions will also affect defining secondary treatments and effectiveness of patients by the changes in the treatment protocols as well. And then censoring bias, social determinants of health will likely correlate with data acquisition frequency and follow-up. And lastly is causality. How will we generate hypotheses for differences in observations that we observe? So if we see a difference in prescribing patterns, is that because the UC system doesn't offer the drug, or is it because the insurance won't pay for it? Or is it because the patient don't want the drug or something else? It's just something that can be a potential limitation for us to consider. So with that, I would like to acknowledge the Boot Lab for taking me in as a grad student and teaching me all of the skills that I've learned thus far. And I would like to thank the CERSI program for giving me the opportunity to present and be a scholar in this program.
Thank you so much, Jason. This is fantastic. I've seen some of that original work, and this extension of now looking at differences by race ethnicity seems just incredibly important, and really looking forward to finding out what you learn.
Thank you.
Thank you. And our final presentation in this panel will be Xiaoting Shi from Yale University, I believe, talking about quantitative bias analysis methods.
Yeah, thanks for the introduction. Can you hear me all right?
Yes, you're perfect.
Nice. I'm Xiaoting. I'm a PhD student within the Department of Environmental Health Science at Yale School of Public Health. It's my great honor today to join the seminar and present our work, which is a systematic review on quantitative bias analysis methods for epidemiological studies. And in this project, I was mentored by Drs. Josh Wallach, Ziyan Liu, and Joe Ross. So I will start with my disclosures. I am supported by the China Scholarship Council and Yale Graduate School of Arts and Science in the past 36 months, And our work is funded by the US Food and Drug Administration, FDA, and of course the CERSI Scholar Program. So I wanted to talk a little bit about the background of our study. Over the past few years, the FDA has developed a framework and guidance, including the 21st Century Cures Act, for utilizing the real-world data, which includes data from electronic health records, claims data, billing data, etc., and observational studies to inform regulatory decision-making. However, we all know, and I believe it's also mentioned briefly in one of the chats, is that observational studies, they have inherent limitations to various biases, which can largely impact their ability to infer causality. Therefore, analytical methods are needed to help understand the impact of biases on study results to help us evaluate the validity of the study findings. So quantitative bias analysis, or QBA methods, they are often applied to observational studies as sensitivity analysis to test the robustness of the study findings. And they're defined as analytical methods that measure the impact of systematic errors in terms of their direction, magnitude, and uncertainty on study results. And typically, they can be classified into 4 categories. And this table very well outlines the differences across these 4 approaches, which mainly is the number of biases they address at a time and how they assign values to bias parameters. But basically, some methods, they are simple and relatively straightforward to use, while other methods, they require more advanced modeling techniques. So let's take a look of a very commonly used QBA method called e-value. So here is the, here is the DAG that depicts the relationship between a classical exposure outcome relationship in epidemiological study, and unavoidably there's always unmeasured confounder that can potentially distort the association that we observed. So the basic idea of e-value is to measure the minimum strength of association that an unmeasured confounder would need to have with the exposure and outcome to fully explain away the observed association. So e-value is just one of the QBA methods that have been proposed across the literature, and in the past few decades there have been various QBA methods proposed. However, little is known about the specific type of QBA methods that are appropriate for different study designs. And while some QBA methods, they are complicated and require statistical and modeling expertise, which can be challenging for researchers to use. The other more relatively straightforward QBA methods, like the e-value method we briefly talked about, they can also easily be misused or be misinterpreted. So it is necessary for us to have a robust understanding of the characteristics across different QBA methods and to help identify the best QBA methods for different study designs. Therefore, we conduct a systematic review on all the QBA methods that have been proposed for epidemiological studies. And specifically, we aim to first systematically identify, summarize, and compare all the QBA methods that have been proposed in the existing literature. And second, to summarize the key differences between the different QBA methods in terms of their required parameters, their assumptions, strengths and limitations, etc. And our ultimate goal is to develop a user-friendly decision tree that can help investigators to identify the best QBA methods for their study. So to systematically identify all the QBA methods, we work with an experienced medical librarian to develop search strategies across 4 leading medical databases. And here's the one we developed for the Medline databases. And besides database searches, we will also review major epidemiological and bias analysis textbooks to make sure we also capture all the QBA methods that have been proposed there. And lastly, we will also manually review all the references included in previous articles on QBA applications. So after we identify all the studies of our interest, we will include English language articles that describe or evaluate or compare QBA methods for observational studies and non-randomized experimental studies without date limits. However, we will not include articles that propose methods for non-human subjects or articles that only use QBA as their sensitivity analysis, or if the type of the article are conference abstracts, commentaries, or corrections. So after we include the QBA methods of our interest, in terms of the key information we wanted to abstract from the QBA methods, I figure it will be more straightforward if I can just walk you through a method that we already abstract, the one I've already talked about, eValue method. So for each QBA method, we will first abstract the name of the QBA method and what category it belongs to, and what study design it applies to, and what's the result of interest of this QBA method, and what's the required data structure for the exposure, outcome, and confounders, what type of bias this QBA method aims to address, and what's the required parameters, and what's the mathematical formula for this QBA method, what's the data assumption behind it, and what's the recommended software that's available, and what's the output and interpretation of the output, and what's the consideration and pros and cons of these methods. So after we collect all the important information across all the identified QBA methods, we aim to develop a decision tree. And this is a very rough draft of the decision tree, because as you can see, it's not really look like a tree right now. But the basic idea is to help researchers and regulators determine the type of QBA methods that's most suitable for their study design. So if a researcher comes in with their study they already conducted, and depend on the characteristics of their studies, including what type of data they have, what's the study design, what's the data structure of the exposure or outcome and confounder they are looking at, they can find the recommended QBA methods that's out there, and what's the available software for this QBA methods, and what's the strengths and limitation between these different QBA methods that's available. So that's about our methodology. And in terms of where are we are finalizing the title abstract screening of more than 7,700 studies, and we are moving to the food test screening of the papers. And we are also constantly refining our protocol, and we are going to register our protocol on Prospero as well. And we've already piloted several QBA methods to make sure our data extraction form are able to capture all the important information. So given our study is still ongoing, I can talk a little bit about the potential implications of our study. So the comprehensive summary of all the QBA methods across the literature and the decision tree we develop, hopefully they can help increase the utilization of QBA methods, and can also lead to the development of reference materials and potential guidelines for QBA methods. And we're also hoping the decision tree can help researchers and regulators who conduct epidemiological studies to identify the optimal QBA methods for their study. And our work is also in alignment with the FDA Research Priority Area 3C, which is to develop methods to leverage large complex data to inform regulatory decision-making, including the use of real-world data. So in terms of the limitations/challenges of our study is that we already seen many iterations of the same QBA method, and we've also seen a decent amount of QBA methods that are computationally intensive. So I will work closely with the people in our team who have expertise in statistics and methodology to make sure we will capture the important characteristics of these studies. And we can also foresee that the data extraction form we develop may not work for every QBA method. So we will also constantly refine our data abstraction form to make sure it can capture all the important information. So at the very end, I wanted to thank the FDA and the CERSI program for supporting this work, and thank the audience for listening. And most importantly, I want to give a huge thank you to our fantastic team at Yale, Mayo Clinics, and the FDA, without whom this work would not be possible. And that's all about my presentation, and I'm happy to take any questions.
This was great. Thank you so much, Xiaoting. So this was, I am really looking forward to having this as a resource to use in my future studies. So let's move on to the Q&A. So we have a question to you, Alex, from Joe. I don't know if Joe actually wants to just ask it or if he wants me to read it. He's just.
Sorry, no, I'm happy to ask it. Alex, I mean, one of the things that I was thinking about when I was looking at your presentation, and I don't think it's true, but is there any rule or regulation against using a predicate with a recall or a safety problem as a predicate?
To my understanding, there are no rules so long as the product was recalled voluntarily. So if the firm takes it off the market and the FDA doesn't formally say, like, this product is off the market now, then it's still fair game as a predicate.
That's fascinating. So a firm could recall it voluntarily and reintroduce it, right?
Or not.
Fix it or not, yeah. And it could be used as a predicate. Because you can't use something as a predicate if it's been withdrawn, can you?
As long as it either was approved by the FDA or it was on the market prior to, like, the FDA's authority to regulate medical devices, you can use it as a predicate. So it doesn't have to be in circulation anymore.
Oh, that's fascinating.
You don't have to market it. Yeah.
Interesting. I sent you a note that they should probably look to have like a Goldilocks approach.
Yeah, that's interesting. We actually did not find any evidence of that. So I didn't present it. We also look at the age of the oldest predicate, and we find that that effect is insignificant and pretty close to zero. So it's really that newest predicate age that's driving our results. But the caveat to that is, we're only looking at recalls, which is like a very narrow aspect of safety. So for other safety or efficacy reasons, you might want more of a Goldilocks window, but we don't see any like increasing and then decreasing effect like that in our data.
It's a great project, and I'm so impressed by the sort of machine learning algorithm you've used to identify, because that really prohibits other research.
Thanks.
So I have like kind of it's not a technical question because it's not even that smart, but it's just, so what do you do about the fact that like some of your stuff has been on the market a lot longer and so has more of an opportunity to present for recalls?
Yeah, right now we just sort of chalk that up to, so we use like year fixed effects. So that's like sort of doing that. One thing we can't control for is like number of devices on the market. So like, to some extent we're like adjusting for like product types, but if like one model is much more popular and maybe has like a better chance of being recalled just because more patients are like touching it, we can't measure that. And that's just like an underlying issue with like the entire post-market surveillance set of data sets that the FDA has. So we basically put a lot of faith in year fixed effects and product fixed effects, but we also did like time to event models rather than just like a binary outcome. So like a survival analysis, and the results qualitatively look pretty similar.
God, I mean, that solves it too, right? So Jason, I asked a question and you did respond, but I'm curious whether you have anything else you wanted to say about it. So one of the things that you raised in your limitations was that you're not really sure like how this is happening or why this is happening. And I was curious whether you'll be able to use notes, because I know it can be tough to get access to notes if you're working with de-identified data, but it seems like that'd be a great source to try to figure out some of that information about why people are switching or why they started a particular medication.
Yes, thank you for asking that. So in the initial study, we won't be using clinical notes, but as we move further and expand on the research and understanding and trying to figure out what the underlying causes are, we will begin to use natural language processing to be able to extract the clinical notes and figure out exactly what is going on between the patients and the doctors, and as a result of treatment distribution.
Great, thank you.
Molly,
Yeah.
I was going to ask a different question to Jason. I was really interested in your presentation and the use of the data, thinking about I understand certainly why there'll be differences in treatment use across the population, particularly by social determinants of health. I wonder why you think there'll be a heterogeneity in the treatment effects themselves once you account for use. So once somebody's starting something, is it because of other comorbidities or other access to other medications that they're on? Because this I actually think is going to have really important implications on the regulatory side as you're kind of what you expect safety and benefits to be, in the sort of real world population. So I'm just wondering if you could expound on that a little bit more.
Well, yes. So we expect comorbidities to have an effect on the health outcomes as well. But the thing is that we understand with social determinants of health that there are underlying causes such as access to food or access to healthcare that can also play an effect in drug effectiveness, whether it's the be able to adhere to drug guidelines, like whether you're taking the prescription once a day or twice a day. And if you have a longer distance to pharmacy or a longer distance to wherever you get your drugs from, that can play an effect on health outcomes, as well as food access and food quality can also play an effect on the comorbidities such as BMI, or leading to other heart diseases, maybe like MI, myocardial ischemia, things like that, that can also play an effect on the drug effectiveness and the health outcomes.
It's really interesting when you think about, is FDA's role to regulate the products, or is it FDA's role as a public health agency to be thinking through these things as they're sort of considering the safety and effectiveness of product use?
Yes, well, I think it's extremely important because, say, for instance, in clinical trials, you have a drug where maybe diversity in the clinical trials may resort only to race and ethnicity. But if you're not taking into effect socioeconomic status and location, because you can have someone who is Black, or you can have someone who's part of the Latinx community, or someone who is white, who is also in the same socioeconomic bracket, that those drug outcomes in the clinical trial may not vary as greatly as if you have someone that's in a higher socioeconomic status and you have patients in the clinical trials of lower socioeconomic status. Then you will see more variation in the outcome of the clinical trial.
That's great. Thank you.
Could I ask?
Oh. Go ahead. Yep.
I was just wondering, if you guys are going to be, I'm sure you'll be looking at like the cost of the medication and how that affects, how well people adhere to the treatment. Things obviously like metformin's pretty cheap, but Lantus is really expensive, and just looking at the different costs of everything and the conversations around that.
Yes, so we're looking at the cost effectiveness too, and how that varies between the disadvantaged areas and those who are least disadvantaged, and see what exactly is the distribution across each ADI decile in regards to cost and treatment selection.
Great. Xiaoting, I wonder if you can talk a bit about some of the different approaches that you're finding so far. Are you finding like most of the stuff is kind of one-off, or are you finding a lot of the same methods over and over again?
Yeah, this is a good question. So basically, we found various methods so far. Some of like the e-value, they're very straightforward and easy to use. But some methods, they're very mathematical and statistical, and we might need some experts like in biostats and mathematics and computational science maybe to help us out. But these methods, they are looking very different and all have like different like requirements and like assumptions. So we might need like extra expertise.
Well, thank you all three. These were fantastic presentations and really interesting work. And I am, as always, very excited to see your final products. And that puts us exactly on time for the final panel.
Pretty good, Molly. You're showing off now. So we will go to our final panel. And this was by theme, the grab bag. Where we could not put anything else. The first presentation by Sarah Mullen is actually not happening. I don't think Sarah's here. Sarah had a baby a couple of days ago, and we strongly encouraged her not to attend the CERSI Scholars presentation. She was like, I might be late with my slides. We said, do not come. So we're going to go to our second presentation. Arthur Subaswamy is going to be presenting on assessing the robustness of clinical machine learning models to changes in context of use.
Thank you. Great. Can you see my slides?
Yes, perfect.
Awesome. Yeah, thanks so much for the opportunity. I'm Others. I'm a computer science PhD candidate at Hopkins, and I'm really excited to tell you about some of our work on assessing the robustness of clinical machine learning models to changes in context and use. This is work that is done by our group at Hopkins, and along with collaboration with a really great team at the FDA. So I'm excited to tell you about this. There's a lot of promising potential and hype right now about the use of artificial intelligence and machine learning in healthcare. In particular, this has been driven by studies showing promising performance of these types of models in what I like to call sort of laboratory settings. So on retrospective, rather simplified diagnostic tasks, machine learning models have shown the ability to achieve near human clinician level levels of performance, again, on these simplified diagnostic tasks. And so in part based on these great results, there's been a growing number of commercial products developed using this kind of technology. So there's an FDA approved, there's a publicly listed database of FDA approved machine learning based medical devices. And there's been over 300 such approvals since 2016. That being said, there's a number of challenges between training and deployment. So between developing these models, again, in these kinds of laboratory settings, and then their actual use and deployment in real clinical settings. One of the challenges, and the one I'm going to focus on, and that's what our project revolves around, is the challenge of external validity. So this is a problem in which a model doesn't generalize beyond the particular site, population, or data set that it was developed on. One example of this, here I've pulled a pretty well-known paper by a group at Mount Sinai, where what they did was they developed a model to diagnose pneumonia from chest x-rays. And what they found was that when they evaluated their model on held out data from the site that they developed it on, they found that it performed really well. But when they then evaluated it on cohorts from data sets from 2 other medical centers that were not the one that it was developed on, they found that there were really significant deterioration in performance. And so the model failed to generalize from the site that it was trained on to these new sites. And when they probed the model in order to determine, why was this happening, what they found was that the model was making use of these style features within the X-ray. So in particular, what's highlighted in the images here is this token, which tells you about the orientation of the X-ray. Is it a front to back or a back to front X-ray? And what they found was that the model was primarily basing its predictions of whether or not the X-ray demonstrated a pneumonia case or not based on the choice of this token. So basically based on the orientation of the X-ray. And what it's exploiting there is a lot of policy-based, so clinical practice pattern-based information about the choice of equipment. Is it a portable X-ray machine? What are the hospital policies and protocols? What are the types of cases that you see in a given hospital department? And so these various style-based associations cause the model to fail to generalize. And so this is indicative of this general problem of a model can look good when you validate it on a given data set, but then it fails to have that performance fails to hold under these kinds of changes. So the question then is, how can we evaluate external validity? And this evaluation question is really what our project has centered around. But there's a number of challenges in evaluating external validity. First, our existing statistical tools for performing model evaluation, things like cross-validation and the bootstrap, they focus on data that looks similar to the training data. So what this means is that these are ways to get performance estimates, to estimate the performance on new data that looks similar or comes from the same distribution as the training data. And so in this way, these tools are really great, but they're useful for assessing internal validity rather than external validity. So when we're interested in external validity, the gold standard has been to evaluate performance on large, diverse, independently collected data sets. So essentially to just empirically evaluate performance on new data sets. But this has a number of limitations. One, we're limited by the availability of these data sets. And in particular, when we're talking about providing evidence prior to the approval of a device, it's hard to have access to a large number of evaluation data sets. If we don't have this data, it's very costly to collect new data. And in particular, it's also very difficult to perform targeted data collection. And then finally, if we don't understand how the data sets differ, it's unclear what this empirical evaluation really tells us about the robustness of a model. So if the different data sets are very similar to each other, then what real value have we gained by doing this empirical evaluation across these data sets? So with that as the backdrop, the goal of our study has really been to answer questions, given that we want to use the evaluation data that we have available. So can we answer questions like, what differences across environments can lead to model failures? How stable is a model's performance to changes in environment? And how can we identify populations and settings in which the model performs poorly? So for the first part of our project, what we did was we developed a new statistical methodology to be able to use available evaluation data to answer these types of questions. And that's in a methodological paper that was published last year. And what we did was we developed a methodology for performing a stability analysis. So the goal of a stability analysis is to characterize how a model performs across a range of different populations and environments. And so because we're looking at a range of different settings, this allows us to assess external validity. The particular strategy is to identify subpopulations of an evaluation cohort on which a model has its worst case error rates, basically. And so to just give a demonstration of this approach and give some intuition for how it works and how we can use it, I'll talk about a hypothetical example for a medical risk prediction problem. So suppose we have a diagnostic model for predicting the presence of a disease from patient data. So it uses information about patient demographics, their disease burden, comorbidities, as well as physiologic information contained in the electronic health records. And what we want to understand is, how does the performance of the model change as we see shifts in the population mix? And let's, for now, just talk about shifts in, say, age and reported race. So we're looking to analyze the stability to shifts in changes in the age and race distribution of the population. What the output of our procedure is it's this model sensitivity curve. So on the y-axis, we have model accuracy, so higher is better, for diagnosing the target condition. And then on the x-axis, we have this subpopulation size. So for a subpopulation of size of 1 at the very right here, this is just the performance of the model on the entire evaluation data set. As we go left, we're looking at smaller and smaller subpopulations such that each point is our estimate of the model's performance on the worst subpopulation of a given size. And so we can now go about answering our question of, how does performance vary based on age and race? So one way that we can do this, and one type of question we might want to ask, is if there's an existing baseline model or standard of care, on whom does the model's performance dip below that baseline performance? So here, what we can do is we can compare the performance of the model we're evaluating in blue to this baseline in orange on these worst subpopulations, and look and use that baseline model to define tolerable performance thresholds. And so what we see is that while the new target model outperforms the baseline model for a wide variety of subpopulation sizes, for the worst 10% subpopulation and below, we see that the performance is poor. And so we can say, who's in this subpopulation and what are the characteristics of these people? And so what we do is we can investigate the statistics of these populations. So on the right here, we have the distribution, the age distribution for the full data set, as well as the race distribution. And on the left here, we have the age and race distribution again for these worst case 10% subpopulation. And what we see is that in particular, one striking difference is that there's a difference in the age distribution. So while patients age range 20 through 90 are well represented in the full data set, in the worst 10% subpopulation, there's a higher concentration of older patients between age 60 and 80. And so this gives us a way of saying that performance is considerably worse amongst older adults, but doesn't seem to vary by race. The race distributions are practically identical. And so this forms the base for further exploration. This gives us some hypotheses to go forward and test about understanding, why is there a performance disparity here? So that was just, a simple kind of vignette to demonstrate it. What we're doing in the second stage of our project is we're wrapping up applying this stability analysis to a published and deployed patient deterioration model, so risk monitoring model. And what this lets us do is to identify unknown unknowns. So what factors are relevant for defining intersectional subgroups? When we have known subgroups of interest defined, say, with respect to a given demographic, it's easy enough to measure performance sort of stratified by these. But once we start looking at a large number of factors which may be relevant and trying to look intersectionally across them, it's much harder to evaluate and communicate this. And so identifying these unknown unknowns is a challenge that we're addressing with this. Again, this gives us a way to do exploratory analysis and to do hypothesis generation about possible failure modes for a model. In deployment settings, what are the types of populations or also operating conditions that a model could fail in? And then finally, one of the key insights from this work is that we can exploit the variation within a data set in order to be able to evaluate performance over a range of settings and populations, and thus get a better sense of being able to evaluate external validity even without having the ability to collect new data. So thanks, and I'm happy to take questions in the chat or during the Q&A.
That's great, terrific. No, let's hold to the Q&A at the end if that's okay. So our next presentation in the session is from Silver Akafaji, who's going to be presenting on pharmacokinetic insights to improve breast cancer endocrine therapies in the I-SPY2 trial.
Thanks, Joseph. I'll share my screen. Does this look good?
It looks great, thank you.
Great, thanks. Okay, so hi everyone. Like Joseph said, my name is Silver. I am a second year PhD student at UCSF, like Jason. And today I'll be telling you about one project that I'll be working on throughout my thesis here at UCSF. I'll start with the disease background. So breast cancer, as you can see here, it's been, it has more than 2.3 million women that were diagnosed with breast cancer worldwide, and almost 700,000 of them died due to relapse or recurrence of metastatic disease. As for receptor, common receptor subtypes, including the most commonly one, which is the hormone receptor positive, and human epidermal growth factor receptor 2 negative, that will be my focus mainly. And the stages differ depending on its basically spread to the lymph nodes or other organs. It's screened with multiple imaging techniques like MRI, mammography, treated with targeted therapies, endocrine therapy, which will be my focus, and other immunotherapy as well as surgery.
its 5-year relative survival rate has been increased in recent years to 90% due to the advancements of these treatments. Now, my work will be based on I-SPY 2 trial, which stands for Investigation of Serial Studies to Predict Your Therapeutic Response with Imaging and Molecular Analysis. It's like I-SPY with my little I, your favorite treatment. This is for patients with clinically high-risk breast cancer. So they present with tumor size of more than 2 centimeters. It's locally advanced, so an early stage 2 and 3. It's a phase 2 trial, and it's adaptively randomized using the receptor subtypes that are introduced in addition to a molecular test that I will introduce later. It's a platform trial, so it can test up to 5 agents at a time. And it uses an extensive platform of biomarkers to basically predict response and follow tumor progression across the trial. It's in a neoadjuvant setting, so these are treatments that are given before the surgery. And it uses an early surrogate endpoint called pathological complete response, or PCR, measured at surgery from the tumor sample using pathology. It has more than 2,000 patients enrolled currently, with a screening rate of 400 patients a year. And this is the longest running platform trial in breast cancer. There are so many participating organizations. Those are just a few of them, actually, and funders, including the FDA. They've been really supportive since 2000, actually, 2010. So it's been running for almost 12 years now. So the genetic test that I mentioned earlier is called MammaPrint, which was FDA approved, and it was designed by my PI, Laura Vannevier. It's a genetic test that uses an activity of 70 genes, 70 breast cancer genes, to determine their 5 to 10 year relapse risk for women diagnosed with early stage breast cancer. So those who are low risk are called MammaPrint low. They're at 5% risk of recurrence within 10 years. And those are high risk, they're at 29% risk of recurrence. Why is this important? If they are at low risk, then they can actually avoid chemotherapy and move on with less aggressive therapies and really avoid unnecessary toxicities. So these patients that are clinically high risk, so these are HR positive, HER2 negative patients with molecularly low risk, so MammaPrint low, chemotherapy is not effective for them. It's been seen in multiple trials, actually. And they actually still have significant long-term risk of recurrence despite using adjuvant, so post-surgery therapy. Now, the question is, maybe they can benefit from neoadjuvant therapy, so given before surgery. And that's where I-SPY 2 sub-study comes into play. So usually, like I said earlier, patients present with a tumor size more than 2 centimeters. They get screened and they undergo core biopsy to assess their eligibility for the trial. And they get stratified basically adaptively by their receptor subtype and the molecular test. Now, those who are, like I said, MammaPrint low and HR positive, HER2 negative patients, they go to this sub-study called Endocrine Optimization Protocol. So it's a pilot study within the main I-SPY 2 trial. Now, the other ones with MammaPrint high on the right, these are patients who undergo chemotherapy as well as immunotherapy. They're testing currently these 3 agents listed in the AOP study. And my focus will be on actually one of these arms. So we have 120 patients total right now. They're finishing enrollment in July, and they undergo these treatments for 6 months. Now, my focus would be on one arm, which is the one in the middle where it says 10 patient safety PK run-in. So these are patients undertaking these 2 endocrine therapies together, amcinestrine and abemaciclib. The rationale behind this kind of use of these 2 treatments comes from this other phase 1/2 ongoing trial called AMIRA. And they use amcinestrine as monotherapy in combination with another targeted therapy called palbociclib in the same patient population that's being tested in I-SPY 2. And they saw really good PK behavior, so really good bioavailability and efficacy, encouraging actually efficacy at 200 milligram of amcinestrine given daily. Now, traditionally, fulvestrant is actually the only selective estrogen receptor degrader approved for breast cancer patients in this patient population, HR positive, HER2 negative. But the problem with fulvestrant is that it's given as 2 intramuscular injections monthly, and it has very limited PK. So patients end up having a lot of less efficacious responses. Now, our investigational drug of interest is amcinestrine, which is now an investigational oral SERD. So it's given orally rather than injections, and it has better PK behavior because of its efficacy. So what happens is it doesn't only degrade estrogen receptor, but it also induces the inactive conformation of ER, and therefore has better efficacy with this half-life of 15.2 hours. And what's usually also known and also the FDA approved, abemaciclib as a CDK4/6 inhibitor acts on the retinoblastoma protein to prevent cellular proliferation of these cancer cells. It's usually administered with fulvestrant. And that's what we're trying to kind of replace fulvestrant with amcinestrine in the presence of abemaciclib at the similar dose that's been FDA approved. So together, we think that, as shown here on the diagram on the right, that both together, these 2 drugs can show an orthogonal mechanism of action and hopefully minimum overlapping adverse events and profiles. The problem with these 2 is they have an underlying cytochrome P450/3A4 mediated drug-drug interaction. And the way it goes, basically just a typical pharmacokinetic physiological mechanism, the victim of drug gets metabolized in the liver through cytochrome P450/3A4. And there's either a perpetuator, so either an inducer or an inhibitor that affects the exposure of the victim, which is exactly what happened in AMEERA when they tested palbociclib and amcinestrine. So palbo is metabolized by CYP3A4. Amcinestrine is a moderate inducer based on preclinical and clinical studies. And they saw that the amcinestrine dose proposed in this phase 1/2 study reduced palbociclib exposure by the percentages listed. And they moved on with 2 different dosage, one for monotherapy, and the other one was reduced to 200 for 400 to 200 because of this DDI interaction. And this DDI effect is actually expected to appear in other CDK4/6 inhibitors now used in I-SPY2, which is abemaciclib, because it's also primarily metabolized by CYP3A4. So we expect a similar mechanism. Abemaciclib is hepatically metabolized, which is the main route of clearance. And it's given 2 famous metabolites, M2 and M20, and amcinestrine is acting as a moderate inducer. So the question that I'm trying to answer is how much of an effect is amcinestrine going to exert on abemaciclib in terms of exposure, and hopefully be able to visualize the pharmacokinetic profile through time and concentration curves through my modeling. So population pharmacokinetic would be my method of assessing this magnitude of drug-drug interaction. So we'll quantify hopefully the DDI effect, and that will allow us to inform an optimal dose through this analysis, and hopefully examine the variability between these patients through this modeling method. So the approach will be to develop a model for each of these drugs separately, and hopefully measure the increase in the hepatic clearance of abemaciclib because of the presence of amcinestrine, and estimate its overall exposure, or what we call area under the curve, and its minimum concentration at the given dose to see if it actually achieves target exposures. Some of the limitations would be having data below the level of quantification, and could be that the sample size may be inadequate to identify covariates like demographics, age, race, ethnicity on the effective PK profiles. And they could be also, a sampling could have some errors in capturing the absorption and elimination phases to actually get a good looking PK profile. Now, some of the implications, like I said, we can optimize the dose, which is great, and allow for less toxicity without sacrificing efficacy. We can actually advance regulatory science, right? So this is a huge topic of interest for the FDA right now. A lot of articles were recently released in many journals and media sources about drug dosing and how can we optimize the dose, including the FDA's recent Project Optimus. And that's basically steering us towards avoiding defining a maximum tolerated dose and instead using population PK methods to inform dosing rather than just saying more is better and introducing unnecessary toxicities for these patients. And of course, we base our work all from the guidance for population PK created by the FDA. So altogether, it's a great full picture. Thank you all for listening. And I also want to thank my PIs and the UCSF Stanford CERSI team for having me in the program. And I'll take questions later or now.
Thank you, Silver. Yeah, we'll do questions at the end, but this is so fascinating. And I think it illustrates the value of making clinical trial data available to young investigators like yourself for work like this, because lots of times big PI labs can't take on this, but there's people like you who are really ready to get started, and shared data really enables work like this, and the FDA could play a big role in that. So thank you for your presentation.
Thank you.
Our next presentation is from Delaney Liskey, and the title is The Utility of OCT Papillary Retinal Nerve Fiber Layer Thickness in Differentiating Recurrent Optic Neuritis. Delaney, the floor is yours.
Thank you so much. Cool. Great. Well, thank you. So my name is Delaney, and I'm a first-year regenerative sciences PhD student at the Mayo Clinic. And thanks to the generous support of the CERSI Scholars program, I've had the wonderful opportunity of working with Dr. John Chen and our tremendous colleagues within the Center for Multiple Sclerosis and Autoimmune Neurology at the Mayo Clinic. And we slightly changed the title, but it's called The Utility of OCT Parapapillary Retinal Nerve Fiber Layer in Recurrent Optic Neuritis. And so optic neuritis is one of the most common inflammatory conditions of the optic nerve, affecting about 1 to 5 people in every 1,000. In fact, optic neuritis is the most common reason that individuals between the ages of 18 to 45 develop subacute loss of vision. However, it can affect anyone at any age. And this occurs when the optic nerve, which is a bundle of nerve fibers that connects the eye to the brain, becomes inflamed and is swollen. And as a result, patients typically develop monocular vision loss or vision loss in one eye that worsens over 3 to 7 days after the vision initially begins to shift. So it's a relatively common process that can have life-altering effects on an individual's quality of life. And so optic neuritis is one of my favorite topics to discuss due to the tremendous advancements that we've made for our understanding of it in the past few years. And so in follow-up with the optic neuritis treatment trial from 1992, it was determined that about 57% of patients who have had optic neuritis ultimately went on to develop an inflammatory condition of the brain and the spinal cord known as multiple sclerosis or MS. And in recent years, there's been 2 recently described antibody-mediated distinct diseases from MS that result in similar inflammatory processes. And these conditions are neuromyelitis optica spectrum disorder, or NMOSD, and myelin oligodendrocyte glycoprotein antibody disease, or MOGAD. And so similar to MS, both of these conditions can result in optic neuritis as well, but they tend to cause more severe optic neuritis. However, there still remains a relatively large subgroup of patients with optic neuritis that are negative for these conditions. In fact, 29% of cases are considered idiopathic. And so this poses a particular challenge to the field of MS and optic neuritis related research due to the variability amongst cases, even within the same disease subgroup. So when we go to examine potential optic neuritis attacks, we typically have patients undergo a comprehensive ophthalmic exam that provides us with specific metrics regarding retinal health. And so at the bottom of my slide, I'm showing a visual field test, and typically we see a field defect in optic neuritis. And to my right, I'm showing an image of the retina and the optic nerve with mild edema from a recent optic neuritis attack. However, these imaging techniques may not capture active optic neuritis, as the edema can be very subtle. So I'm going to focus on an imaging technique called optical coherence tomography, or OCT. And this is a non-invasive ophthalmic imaging technique that is regularly used in eye exams, especially for glaucoma. And so similar to ultrasound, it uses non-infrared light waves that reflect off retinal cells to create real-time images of the retinal nerve fiber layer, or RNFL, all while taking its measurement in approximately 1.2 seconds. And so it's considered highly reproducible as the test-retest variability in OCT is approximately 5 microns. And so we are interested in applying this non-invasive imaging approach to confirming recurrent optic neuritis. And so recently we determined that OCT images of patients with MOGAD and MS sufficiently quantified RNFL thickness during an initial attack of optic neuritis. And so as a side note, a healthy optic nerve on average is 100 microns. And so here we can see that a patient with MOGAD experiences significant swelling of 215 microns in the left optic nerve during their initial bout of optic neuritis. And on the right side, our example patient with MS only experiences 9 microns of swelling in the right eye during their initial bout of optic neuritis. And so after analyzing about 150 inflamed optic nerves, we determined that patients with MOGAD experienced approximately 45 microns of swelling during an initial optic neuritis attack. However, in patients with MS, optic nerves only swelled an average of 7.5 microns during their initial attack. And just to remind us all again, the variability amongst images is approximately 5 microns. And so in our data set, we were able to determine that 87% of our participants with MOGAD experienced at least 10 microns of swelling, with 100% of patients experiencing at least 5 microns of swelling. And in contrast, only about 38% of the participants with MS experienced at least 10 microns of swelling. Therefore, we determined that OCT is very sensitive in confirming optic neuritis in patients with MOGAD. However, in MS, it may be less sensitive. And due to these findings in this study, upcoming clinical trials on MOGAD-related optic neuritis will use the threshold of 10 microns as an objective sign of optic neuritis. And while the threshold of retinal swelling has been determined at the singular attack level in MOGAD and MS, it has not yet been determined for after multiple attacks of optic neuritis. It has also not yet been determined for NMOSD or idiopathic optic neuritis. However, about 50% of patients with MOGAD and NMOSD, 20% of patients with MS, and 10% of patients with idiopathic optic neuritis will experience multiple attacks during their disease course. In addition, substantial RNFL thinning occurs up to 6 months after an optic neuritis attack. And this is important because an atrophic optic nerve has less axons to swell. Therefore, swelling after more than one attack will likely be less prominent or not at all. And so we propose that OCT parameters can serve as a non-invasive imaging technique to help confirm active recurrent optic neuritis attacks within the distinct disease subgroups. And so from here, we will be able to generate thresholds regarding the amount of swelling that occurs. And this will be a result of the number of prior optic neuritis attacks, amount of consequent RNFL thinning, in particular disease subgroup. Therefore, we hypothesize that there will be a threshold of RNFL thinning in which recurrent optic neuritis will not cause thickening of the RNFL. And this threshold will be important for clinical practice and clinical trials. And so our project really has one overarching aim, and that's to investigate the amount of absolute RNFL swelling and consequent thinning in recurrent attacks of optic neuritis. And so just to break this down a bit further, we're investigating the amount of swelling after multiple bouts of optic neuritis. And so to do this, patients have had to have undergone OCT imaging at least 6 months after the previous bout of optic neuritis. And this will be considered the patient's baseline. And secondly, the patient will have had to have undergone OCT imaging within 2 weeks of the active attack in the same eye. And so this study is a multi-centered retrospective case series of patients with a clinical diagnosis of MS, MOGAD, NMOSD, and idiopathic recurrent optic neuritis. And optic neuritis is defined clinically by meeting 3 or more of the following criteria in the blue table. And patients with the respective disease subgroups meet the respective diagnostic criteria. And so all imaging was performed by Cirrus HD OCT machines. And for the sake of time, we excluded images with low signal strength and artifacts, et cetera. And so our preliminary findings suggest that patients with recurrent optic neuritis do not experience swelling if the prior baseline RNFL thickness was less than 70 microns. And so on the left-hand side, we can see that on average, patients experience about 17.8 microns of swelling if the prior baseline OCT RNFL thickness is 70 microns or greater. And so on the right-hand side, we can see that patients experience little to no swelling if the baseline OCT RNFL thickness is less than 70 microns. And so these results excitingly suggest that OCT may be sensitive in confirming recurrent bout of optic neuritis in patients with a baseline of 70 microns or greater. However, I would like to mention that this data is preliminary and that we do plan to stratify based off of the number of attacks, disease subgroup, and to determine a more sensitive threshold. And so our overarching goal here is to utilize OCT imaging as a non-invasive technique to standardize clinical trial design in this particular disease context in order to streamline the relevant clinical evaluations and interventions, and to determine the RNFL swelling threshold where OCT is not expected to be used to confirm optic neuritis attacks. And of course, special thanks to our national and global collaborators, as well as to the CERSI Scholars program. Cool. Thank you.
Great job, Delaney. That was terrific.
Thanks so much.
Okay, so for our final presentation of the research seminar, we have Dana Modabar, who's going to be presenting work on revelations on monoclonal antibody stability using mediated electrochemical probing.
Hi, thank you for the introduction. Can everyone see my screen?
Yes, we can.
Good. Okay, perfect. Thank you so much. All right. My name is Dana Modabar. I am a bioengineering PhD student in Dr. Bill Bentley's lab at the University of Maryland. And our project is focusing on characterizing monoclonal antibody stability using our approach called mediated electrochemical probing. And this project is in collaboration with the FDA and NIST. Okay. So first, I want to just start by giving some motivation. That flipped up. So I want to start by giving some motivation behind, background on the motivation behind the project. So antibody therapeutics have come to constitute one of the most rapidly growing sectors in the pharmaceutical market. Importantly, throughout development and manufacturing processes, critical quality attributes need to be characterized, including antibody variants that can be produced due to reduction in oxidation reactions. Typically, in order to characterize these attributes, gold standard analytical methods are used. That includes mass spec, liquid chromatography, capillary electrophoresis. And these methods can provide very detailed characterization of the therapeutic, but they can be expensive, time intensive, and they do require specialized knowledge. So we believe that electrochemical methods using electrodes are also ideal for antibody characterization and can be complementary to these gold standard methods. Electrochemical measurements are not meant to replace the gold standard methods. Rather, they're meant to provide rapid, cost-effective, and potentially high throughput approaches that can be used for process monitoring and control purposes. So electrochemical methods can have many advantages, including rapid, sensitive measurements, as well as connectivity to electronics and control schemes. And that's been previously shown with the use of electrochemical pH and DO probes in the bioreactor. So now I'm just going to focus more on the specifics of our approach, which is called mediated electrochemical probing, or MEEP. It's a fun acronym. And how it works is analogous to how bats use sonar to hunt for prey. Namely, they transmit a signal that can then interact with nearby prey, and then that signal is going to be reflected back to the bat, where it can receive and process that information about its local environment. And so similarly, we show how our method works with the scheme here on the right. So we impose a voltage input that can code what we call redox mediators into their reduced or oxidized states. And these mediators are purposefully added into the solution, and they're going to serve as electron shuttles because electrons can't exist in a solution by themselves. And so the mediators can then diffuse and interact with biological elements in the local environment through the exchange of electrons. And then the mediators will return to the surface of the electrode where information on the redox state can then be decoded by the electrode into an electrical output signal. And these signals can then be further analyzed using what we call signal processing methods. So now I want to show how we can apply our approach to analyze antibodies, such as antibodies and their characteristics, such as when they go what we call interchain disulfide bond reduction. And so reduction is a problem in bioprocessing, and it can occur in the upstream cell culture. And it happens in the bioreactor or when they're harvesting the culture. And reduction can lead to the production of many variants that are shown here on the right. And it needs to be characterized because it can impact the efficacy of your therapeutic. And so we wanted to apply our method to this, and we wanted to first confirm that our methodology can detect cysteine, the amino acid, as it's the primary residue affected in reduction events. And so the electrochemical method that we're using here is called cyclic voltammetry, or CV. And with this technique, a voltage range is scanned with respect to time, and the current response is then measured. And so, as mentioned, we're using what we call redox mediators, and the one we're using here is called ferrocene, or FC. And you can see in that graph in the middle with that green plot, that's our control response. You can see it's this duck-shaped curve with similar amplitudes in the oxidative and reductive peaks. And then when you add the amino acid cysteine to it, you see that the response completely changed. It's a significant alteration in the shape. We have that amplified oxidative peak and that attenuated reductive peak. And the explanation for that change is shown in the schematic here at the bottom. So on the left, you see your mediator ferrocene. We oxidize it with the electrode. And then what happens is it redox cycles with your amino acid, which is what leads to that amplification of that oxidative peak. And conversely, for reduction, since there will be less of that oxidized mediator, you're going to get an attenuation in your reductive peak at the top. Okay, so now that we've established that it can work with cysteine, we wanted to analyze the reduced antibody. Our reduction protocol here is just shown at the top. You take your intact antibody, add a reductant, incubate it, and then we were able to produce reduction fragments that are what we would see in a bioprocessing setting. Then first thing we did was look at the controls. So if you can take your mediator by itself, ferrocene shown in purple, you compare it to it when it's added to just the intact protein, you see that there's really no change in response. And that's just showing us that ferrocene does not interact with the intact protein. That's due to the fact that ferrocene is selective for cysteine residues, and an intact protein shouldn't really have any free cysteine residues in it. But then you can see in these bottom plots here, we measured the reduced antibody over a concentration of about 4 to 1 gram per liter. And our plots show two things. We see that our method is able to detect antibody reduction for all concentrations. You're seeing a major difference in the shapes. And two, we observe a concentration dependent response. Higher concentrations of antibody yield larger oxidative currents, which is likely due to that higher free cysteine concentration. Okay, so I think a really big advantage of our approach is that we can quantify our results using what we're going to call signal metrics. And signal metrics are important because they allow for comparative analysis in a bioprocessing setting. So this approach is analogous to EKG, where a plethora of complex information can be extracted from just the shape of a curve. So the plot on the left here shows how we're defining the different areas of the curve. And then on the right, which shows the equations for the metrics that we're going to apply. And then here, just shown on the graph below, it just shows that all of our metrics align well with our curves. As expected, you're getting higher metrics for your reduced antibody as compared to the intact antibody. And so it was showing what we wanted to see. And an important thing about these metrics is that they can be used cooperatively or independent of one another. And this allows us to focus in on metrics that we think are best suited to our data sets. For example, here, we see the what we're calling a rectification ratio may be best suited as it shows a linearity across the reduced antibody with an R-squared value of 0.99. So it may be a better fit for this data set. And then next, we just wanted to orthogonally confirm the results of our electrochemical method using what we're calling standard bioprocessing approaches. So what would be used in an industrial setting. The first thing we did is just a non-reduced capillary electrophoresis, and it shows the gel on the left. And it basically what it's showing is that it lines with our expected results. You're getting one band for the intact protein and a lot of smaller fragments for the reduced protein, which is exactly what you would expect, and that's what happens when antibody is reduced in an industry setting. And then we also confirmed the thiol content using a free sulfhydryl assay, which just measures the cysteine concentration in your sample. And it basically shows that we got a lot of cysteine for the reduced samples, and it tracks in a concentration dependent manner. Okay, so I kind of just wanted to switch gears here a bit. I talked about how we can apply this method to reduction. Another problem is actually antibody oxidation, and oxidation can occur at all stages of development and also during manufacturing, even storage due to exposure to light and oxygen. So it also needs to be characterized due to effects on the therapeutic stability and efficacy. And so for these studies, we're using NISMAB. It's probably the most well-characterized antibody out there. And we know that it has 8 methionine residues, and methionine is the primary amino acid target during oxidation. And the right figure just shows the structure of the IgG and where the 8 residues are located. There are 5 methionine residues in the Fab region, 3 in the FC region of the protein. So just quickly, we wanted to establish that our method works with the amino acid target methionine. Here, we're using a different redox mediator. It's called iridium or IR. And so we tested it with methionine, and as shown in the plot on the left, we see there's really an amplification in the response for methionine as compared to the control, which is shown in the orange line. Then when methionine is oxidized and becomes methionine sulfoxide, there's a decrease in the response, and it becomes more similar to that of the control. And that's shown in purple. And basically, it shows that our approach is sensitive to methionine residues, and it forms the basis for our oxidized method. So on the right here, quickly, we're just showing the oxidation protocol. This kind of simulates what happens in bioprocessing settings. So we just exposed our protein to hydrogen peroxide. And then on the bottom plot shows the results of our electrochemical measurements. Similar to our methionine results, we see there is an increase in the oxidative response for the intact antibody. Then when the antibody is oxidized, the response decreases, and we're able to discern the difference between an intact and oxidized protein, which was great. So then what we wanted to do was apply our metrics again to our measurements. And for these metrics shown on the left-hand side, we're primarily focusing on that pink area, the oxidative segment of the peak. And just overall, looking at all 4 of those plots on the right, we can see the metrics for the oxidized MAB are decreased as compared to the intact MAB. But we do see that this is a relatively small difference, but using some statistical analyses, we did find that it is significant in a reproducible response. But in order to get reproducibility and significance, we did have to take about 20 replicates, which for our measurements is a lot more than what we were doing for reduction, which only required 3. And then just lastly, we wanted to validate our oxidation protocol, and we did LC-MS-MS peptide mapping with our collaborators at NIST. And importantly, we found that 6 out of the 8 methionine residues, they're highlighted in green on that chart on the left. We found that they're completely oxidized, greater than 98% oxidation. The other 2 are only partially oxidized, and those are highlighted in yellow on the structure. We find that the non-oxidized methionine residues are in the Fab region, one on the heavy, one on the light chain of the protein. And we're hypothesizing they're not oxidized just due to solvent exposure. They're probably buried, which means the hydrogen peroxide can't interact with them. And basically, I think these results really confirm that our method is quite sensitive to redox alterations in the protein. Our method was able to show the difference in response to the oxidation of just 6 residues, which I think is pretty sensitive. And so quickly, I just wanted to go over some of our conclusions. We just find that mediated electrochemical probing can be a quick method to detect redox alterations of proteins. And I think a big advantage is the use of our signal metrics, which can allow for comparative analysis. And overall, we just believe that MEEP can allow for a better understanding of your protein, and it may be well suited for a bioprocessing setting. And just want to acknowledge some of the really important people in this project. Of course, my advisor, Dr. Bill Bentley, all of our colleagues, and of course, all the support from our collaborators at the FDA and NIST. Okay.
Thank you, Dana. That was terrific. The amazing thing about working with part of the CERSI, of course, is that there's just such a broad spectrum of work. I obviously have absolutely no idea about what you do, but you've explained it in a way that was really clear. But maybe we just start our questions and I can ask you. So this is essentially a method that you would use to confirm that a monoclonal antibody product that is stable and can be used in patients. Am I understanding exactly like what its application is? I'm trying to understand.
Yeah, very closely. I know my stuff is a little bit out there from all the other presentations today. But basically, I think, to get approval by the FDA, you're going to have to characterize these proteins really quite well. And typically what they use is those gold standard approaches, like what I'm calling NMR or mass spectrometry. Those methods will provide you that very detailed characterization that the FDA wants to get approval. Our method will not give you that level of detail, and we're not trying to really compete with that level of detail. Rather, our method is supposed to be on the bench in the lab when the process is happening. You can analyze it in real time. And then by doing that, you're able to make adjustments in the bioreactor in order to compensate for these redox alterations in the protein. So it's supposed to be kind of more of a real-time, quick method that can allow process scientists to get information on the fly and make changes as the process is occurring, rather than when you use NMR or mass spec, it's after the fact that you get that information. But yes, it'll tell you if your protein's all chopped up due to reduction, or if the amino acids have been affected due to oxidation. That's pretty important to the FDA.
Great. Thank you for explaining that. I appreciate it. And a really nice project. I saw that there was some conversation in the chat, particularly around Arthur's project. I don't know, Guneet, do you want to ask the question, or Molly, that you had asked Arthur?
Sure. Yeah. So I loved that example that you gave of the poor machine learning getting all off track. And zoning in on something. And I just remembered hearing somebody give a talk about a similar sort of trial, but it was like a competition. The way they won the competition or got the best predictive performance was by just using which site contributed the sample, because there were like these differences across the sites in the prevalence of the disease they were looking for. So I was just curious about how your method can kind of identify those things, or are those things just part of that group of unknown unknowns, where if you don't know to look for it, you don't know that that's what the machine learning is actually, sort of hanging its hat on?
Yeah, great question. So in terms of, how like a methodology like ours works, it's sort of, you need to be able to have candidate factors that could be being exploited by the model. So in the sense of, if you have no metadata, no annotations, like you really don't have anything that corresponds to a label or a proxy for the type of thing that's being exploited by the model, then that's sort of outside the purview of like our methodology, and that represents essentially like a fundamental challenge. But the example you gave of using the particular site that you have, one of the advantages at the evaluation stage is that often if we have a well-curated evaluation data set, so we can have this kind of metadata that lets us do this. So we are evaluating a model using a 5-site data set from the Hopkins Hospital Network. So we have, for each patient, we know which hospital they come from, we know some other information about the circumstances of the admission, et cetera. And we can use those factors in determining which are associated with poor performance. So the set of factors that goes into our method is essentially like this candidate list of possible unknown unknowns. And then what we're doing is we're searching for like a characterization. So essentially again, this notion of these intersectionally defined subgroups. So it could be that patients who were admitted from the emergency department at this hospital is like one group that the model performs poorly on. And that gives you a group, a tangible group that you can go and do further analysis for, just as an example.
That's great. Thank you. Silver, I wanted to ask a quick question that maybe it's sort of another kind of ignorant question because I'm less expert in the kind of work that you're doing. But I'm curious, I mean, it seemed like a lot of the pharmacokinetic data work that you were doing is really focused on efficacy. And I was just curious, how much in your field do people try to balance the sort of safety, tolerability, and efficacy when making approaches around limiting dosage? Is it really about sort of, because you made reference to the sort of maximum tolerable. So I'm just curious about how all kind of parts are balanced.
Right. Yeah. Actually, I was just attending a webinar for Project Optimus by the FDA, and I just learned that a lot of these oncology drugs, drug developers have been just going for the traditional way of defining an optimal dose, which is the maximum tolerated dose. And that's when you have minimal kind of toxicities and the best efficacy. But then a lot of PK studies have already proved in both immunotherapies and endocrine therapies that there's a range, like a wide range of doses that you can test and give exactly the same efficacious response without needing to introduce any unnecessary toxicities. And that's kind of like the goal of my whole project. And that's what the FDA is currently really like a really hot topic right now. Why are we like following this traditional method where we can inform our decisions by using PK modeling, PK/PD modeling specifically?
That's great. No, and that's going to obviously lead to better care for patients. Molly, maybe I can, you and Delaney were going back and forth in the chat. I don't know if you want to just ask your question.
Sure, yeah. So to get to kind of the real utility of this, it sounded like one of the important things would be to kind of standardize inclusion criteria for clinical trials. Can you talk a little bit about that?
Yeah, sorry. So right now, there's no like standard approach for optic neuritis clinical trials. And so a lot of the time patients experience what's called pseudo relapses, which can be, which can occur from, heat or increased heart rate and stuff like that. So it's difficult to determine what is a true optic neuritis attack without undergoing like MRI or any of the other like imaging approaches, but those can be lengthy and difficult to schedule and stuff like that. And so this particular approach, can take a picture in 1.2 seconds. And so that's what we were hoping to achieve with that approach. So
that's great. Thank you.
Thank you.
The far better regulatory science question than what I was going to ask. As soon as Delaney started talking about optic neuritis and MS, I was like, I wonder what she thinks of the Epstein-Barr virus hypothesis that's recently.
Oh, it's a really interesting topic, especially, I mean, in the field of MS. It's really interesting because like, don't quote me on this number, but I think like 97% of the population has Epstein-Barr. It's a very communicable virus. So yeah, no, super interesting research for sure.
Yeah. Any other final questions for our presenters? Well, so I guess with that, I really just wanted to applaud all of the scholar presentations today. I was really so very pleased that we could expand beyond the scholars from the Yale-Mayo Clinic CERSI and invite presentations from the other 3 CERSIs as well as the Harvard MIT Regulatory Science Center. And it's just, I think, enriched the virtual seminar for all of us. And I hope that each of you, uses these connections to build your network and to also, make contact with folks at the FDA and as your work progresses. Molly, I don't know if you want to say any final words before this sort of end of Friday presentation, but I really am just so appreciative and impressed by the work.
Yeah, this has just been fantastic. And thank you all for joining us, and especially to the scholars and to your mentors as well. Please pass along our thanks and our congratulations. These have just been really fantastic presentations. And as Joe kind of alluded to, I mean, I think one of the most exciting things is really the breadth of the topics and the methods and the disciplines that the scholars come from has been just amazing. And all of these things very relevant to the work that the FDA is doing, to the regulatory work that they do, to the science work that they do there, as well as Dr. Morrison was saying this morning. And I think it's one of the most exciting things about being involved in the CERSIs is not only is it like super interesting work, like really scientific work and lots of different disciplines, but it's directly important to something that touches every single one of us every single day, the sort of food and drugs and other things that are the devices that are available to us to help us with our health and safety and quality of life. So thank you all, and please do be in touch with us if there's anything we can do to help you with your future endeavors.
Yeah, I'll just say last thanks to, obviously, to the FDA for supporting the CERSI and especially the Yale-Mayo Clinic CERSI, and to the Yale-Mayo Clinic CERSI staff, especially Jessica Ritchie, for helping us to organize this event. So enjoy the weekend, everyone. Thank you again.
Thank you all.